us, these are the 4 tissues which we come across in our mouth. Hemoglobin, which we see in blood vessels. Melanin, which we see as a pigment of our tissues. Hydroxyapatite. So, yeah, sorry for that. So the melanin is the pigment of the mucosa. Some people have got black gums, some have normal gums. Other is hydroxyapatite, which you see in the bone, in the tooth structure. And last is water, which you see in the bone. So if you see here, the diode and ND-YAG lasers, they have got very good affinity towards this yellow thing. And what is this yellow? Melanin. So this diode laser can be used for depigmentation procedure, but not a hard tissue laser. And similarly, if you see here, diode laser has a very good affinity towards this red line, which is hemoglobin. So they can be used for hemostasis purpose. But a hard tissue laser like these here, they don't work on melanin and hemoglobin, but they cut the tissues very fast. Okay? So now, if we compare this laser with another procedure or another gadget which we use in our practice is electrosurgery. Electrosurgery, if we compare, we find that laser has many more advantages over electrosurgery, like coagulation obviously is better in electrosurgery. That is why in all major surgery they use electrosurgery for coagulation purpose. But lasers have some amount of affinity. Otherwise, incisions are better, excisions are better, flexibility of tip is there, sterilization effect is much better, and most important, healing is fastest in laser as compared to electrosurgery. Electrosurgery really cuts the tissue and damages the tissue too much. Okay, so anything which comes with a price, you have to be very conscious about the safety hazards which are involved with the laser. You have to be very careful when you are using lasers. You have to use proper eyewear. They come under proper gadgets, and everything has to be. You can't just pick up any eyewear and you can start using that. So these controls have to be engineering controls, PP controls, and administrative controls. So how do you select a eyewear? Very important thing. You can't just pick up anything and do it. There's a thing which is known as optical density. Normal sunglasses which we use don't have even an optical density of 1. They have an optical density of 0.2, 0.3. Even this Ray-Ban and all that. So they are not protecting you or anything. And the glasses which you use for light curing composites, those golden colored and orange colored gadgets, they are of no use. Optical density of 4 or 5 is required for laser. This is the eyewear which I use. It says 3 to 5. Now, what does 4 means? That if any light falls, 99.999% of will be absorbed by the glass, and 0.0001 is only going to pass. If more light is passing, it is 100% damaging your retina. So be very careful. Nothing is more precious than eyes. You can really harm your things. So this is how I work with full gadget and everything. So now coming to the clinical aspect, for which basically I am going to motivate you people to buy a laser or have it in your practice. It has role in nearly all specialties, whether it is ortho, conservative, perio, oral implantology. So basically I'll be focusing more on orthodontics, and some things I'll be covering for general dentistry. So coming to some latest things in which we can incorporate laser, like detection of dental caries. A standard method, probing method, or a dental caries dye is there. That really doesn't work. Nobody wants to put that dye and go back with all his mouth. Dental lasers can nowadays be used for detection of dental caries. There are 2 gadgets. One is Diagnodent, other is a laser-induced fluorescence. This is a very common gadget. Diagnodent is an instrument which is recently designed to facilitate the detection of dental caries. It is used for detection of caries on occlusal and smooth surfaces. A small gadget which can be placed in the mouth. It gives a numerical reading. If this reading is more than 10 to 30, you definitely need a therapy for it, whether a patent fissure or you have to drill and fill a cavity. So good gadget to have in your practice. Etching of enamel. Obviously, phosphoric acid is used, easy, simple, and cheapest. But if you have by chance a laser, you can use this because the laser absorbed by the enamel causes the enamel surface to be heated to a high temperature, generating micro cracks in the surface. This aids in enhancing adhesion to the composite. All research has shown these micro cracks are similar to the etching pattern which you see with the hydrophosphoric acid. So you can incorporate this and it really works. You don't have to give that very sore, bad taste to your patient of orthophosphoric acid. Lasers can also be used for curing composites because their wavelengths are nearly same as you have with the light curing things. So, and they need very less time. Pitch 1-2 second or 1 second curing is more than enough to cure even a big thickness of composite. They can be also used for caries prevention. Other than applying fluoride and everything, the laser irradiation of dental hard tissue modifies the calcium to phosphate ratio, reduces the carbonate to phosphorus ratio, thus leads to the formation of more stable and less acid-soluble compounds, which prevents caries. Obviously, all of us know lasers are nowadays used for debonding ceramic braces. Same concept, you put a debonding plier, you pull it, it really hurts to the patient. When you use a laser, it creates heat, there is a coefficient of thermal expansion difference of ceramic and composite, so that breaks and bracket easily comes out without traumatizing the patient. Now coming to few cases which I use in my practice, that is laser whitening. You have done a beautiful case, amazing results, patient still happy. He says, Doctor, मेरे दांत ना अभी भी पीले लग रहे हैं क्योंकि उसने देखेंगे 1.5 साल से. He has not been brushing his teeth properly. There are stains on everything. You can polish your teeth, but then you realize the patient wants more results. You can offer a patient laser whitening. It is very different from all other whitening procedures because here we are safely guarding the gum tissue. We don't allow the material to leach into the tissue. So absolutely no post-operative hypersensitivity, nothing, and amazing results within 1 or 2 hours. See, you can see here, from here, the teeth goes to this place in just 2 hours. That's all. Okay, from here, we are reaching here. Sorry, the quality on the projection is not very clear, but amazing results. As you can see here, we are totally covering the tissue with a dammer, as you do in other cases also, and then you apply the thing. And the laser bleaching agent which you get from the company is very expensive, but you can also use Polar Office Plus. That also works amazing with the laser. Just 2 applications and you can see amazing changes which you see here. From here, we can come here. So these are just few cases I'm sharing. Now coming to another thing which most of us are very much attracted, that is frenectomy. As an orthodontist, there is always a thing that when there is a midline diastema, a large bulbous frenum is one of the causes of it. Okay, a standard and the way we should go ahead is always close the space first, then go for frenectomy rather than doing other way around. Sometimes people say you do the frenectomy first, then close the space. It should not be like this. Why? Because when you do a frenectomy, either a surgical or a laser, before, the scar tissue which forms will not allow the teeth to close. It will act like a spring. As soon as you're going to close it, that scar is going to open up the tissue again. So close the space, hold it tightly, do a surgical or a laser procedure, leave it there, tie the teeth for figure of 8 for a long time of 2 months after that, and then you see that it works. So it has these advantages: shorter duration of surgery, hardly 5 to 10 minutes, simplicity of procedures, absence of post-operative infections, lesser pain and swelling, presence of small or absolutely no scar. Till 5 years back, before I got laser, all these procedures were done by a periodontist. Absolutely wonderful job, but you have to call the patient back for removing the sutures. One of the sutures which on the top was so difficult to remove and patient used to get phobic behind it. With lasers, nothing is required. One more advantage is that the short lip which you see, now one thing which I've come after experience of more than 500 frenectomies, I've realized that if you do a total frenectomy, at times it is a loss. Because when you're doing a total frenectomy, the lip is going to come down. As you can see here, this is immediately post-frenectomy, the lip has come down. In the next photo also you see here, post-frenectomy, lip has come down. But the Dept fibers which you see are holding the lip and alveolus together. So people who have a short lip, on resting position, the lip is going to get down, but when they are going to smile big, the holding of this musculature will not be there. So lip is going to go up more on smiling. So to take care of that, we have started doing a partial superficial frenectomy procedure. It is yet to be quoted somewhere, but I have checked with my periodontist, so that is a better way to do it. We are doing cutting of only superficial fibers, not in-depth fibers. So as you can see, beautiful results. The lip is getting better. The thick bulbous frenum, how do you say? You see here, we have closed the space, tied the teeth with figure of 8, and see the wound is so big. Don't show the wound to the patient. He will get really terrified. But in the evening itself, you will say patient has no problems. A nicely healed frenum you can see here. Okay, so good results. Again a case. So much of lip exposure. Teeth looks much better. Here also you see one mistake which we did here was that we did the procedure but we didn't tie the teeth at figure of 8. You see here? So the teeth space has opened up. That is a key. You have to always tie your teeth. So this is one small video. It will take just 2-3 minutes to
and consolidated all the teeth, and we can see a large frenum. Previously, this procedure was done by a periodontist and a surgery was performed. And
this is just to tell how simple that procedure is.
And there was bleeding involved, and ultimately, so we'll be doing this procedure.
We should do the mode should be continuous mode. They give a pulse mode also, but continuous mode is much better. See how simple, you're just cutting the area.
Not even given a just by spray. See here.
One thing I want to highlight in this small video, all these videos are available on YouTube. This is a very important tip which you should use whether you're doing a blade surgery or a frenectomy by laser.
Because they only cause the
you have to cut into this area, a depth cut.
So
here, these are the circumferential fibers which are the most difficult one to tackle, the transseptal fibers. So cut deep on both the sides, on the labial side as well as on the palatal side. Cut from the back side, very important, which people miss, they only do on the superficial side. So that's why the things they open up. Okay, I'll be just going further. Now next procedure where we need this procedure is Digivectomy and crown lengthening. You might have achieved beautiful results with orthodontics, but you need further adjuncts. So I will just explain you a few cases of that. So gingivectomy can be used to treat gingival hyperplasia, which further provides improved mechanical plaque control. It is a vicious cycle. Whenever you are doing intrusion by mini implants or anything, the bone is resorbing fast, but not the gum tissue. Gum tissue takes months and months and months. So they start accumulating into that area, and patients' brushing gets further bad. So what is happening is more plaque accumulation, more issues, and everything is happening. So gingivectomies are of great help for bonding the braces in patients with short clinical crowns. They are a short clinical crown, you just remove the gum from the top and then do your bonding. The laser-aided gingivectomy procedures do not require the use of surgical dressings. Very important. When you are doing gingivectomies, you have to put a co-pack. Here you don't need to put anything. Very hygienic method to do it. The margins reveal functional and aesthetic results after gingivectomies. So, as I said before, the macro aesthetics are very nicely taken care by orthodontics, but when it comes to micro and mini aesthetics, you have to add these adjuncts. So like this case where we see that we were doing the nice alignment, we achieved, the patient was on some medication, the gums have just grown into the braces. So we have done the gingivectomy with a laser, simple procedure, just 20 minutes, and the teeth have nicely healed in just 1 week time. Nice healing is there. So another case in which everybody had said we'll go for only orthognathic surgery. No, nowadays there are so many good options. So we chose this case. We started with microimplants. 6 microimplants were used to push the whole jaw upwards so that the gummy smile could be taken care. As you can see, we are going further and we have reached a stage where so much of gum hyperplasia is there. So we have reached this stage. See, the distance has reduced drastically between the microimplant and the tooth surface. They have gone back by 4 to 5 mm intrusion. The lower teeth, they were absolutely not visible. Now whole of the lower intrusion incisors are visible. So all this gum tissue which has collected, obviously before you do all these procedures, you have to have a good periodontal probe to check everything. The attachment gingiva, you just keep cutting the things. If you need to do, you have to do a bone trimming also, that is required. So we have done this gingivectomy procedure, and now you see teeth have nicely healed back. You see here and see here, the difference is amazing. But from here we have reached to this stage. From here, after gingivectomy, see the difference is amazing. You have to have something to give good smiles. So starting from here to here, the smile has perfectly changed. So as you see here, things are improving. These were the mechanics which were involved. Another case, beautiful results we have given to the patient. From here, we have given a good smile to her. We did selective extractions and everything, a nice result. But patient still wanted more. Patient always wants more. And if you have a facility to provide it, please provide it. So patient was not very happy with the gingival exposure on this side of the gums. The laterals were not very good. See, you see here. So we did a selective crown lengthening in these teeth. And from here, the gum line is much better now. And the smile has drastically improved. So from here, see, we have done the cutting of gums on these teeth. Here exposure is less on this side, and we have got a beautiful smile. Again, the same case, we were able to give a good result. Patient wanted more. His gum line in the laterals was much less. So we did a spinectomy as required, and we did crown lengthening in the laterals, and now you see the laterals look much better as compared to this place and here. You are able to appreciate the difference? So that is there. One case which I always share, this is one of my best patients. She had said yes for everything. She dedicated wholehearted to the orthodontist, said you do whatever, improve my smile. It was working. So you can see here, after orthodontic, we did first premolar extractions, and we got beautiful result. Everything was looking perfect, but she wanted more. She wanted some crown lengthening, she wanted some depigmentation, and this is the final result we got. So I'm just showing you this case. So this was a case, class 2 case, irregularity. We did bonding, nice result, first premolar extractions, closed up all the spaces, and we got a beautiful result after debonding, but patient was not happy. There was a difference in the height of her gums. There was difference in the color of her gums. So she said, my premolar is not looking, because it was all palatally placed. So we brought it out. So we went for a gingivectomy procedure and crown lengthening. We removed the gum with a laser. And now you see here, beautifully smile. But she said, okay, no, I want a depigmentation of my gums. So we went for a simple depigmentation procedure, not more than 30 minutes. And it makes a wonder. And you can see from here, we have reached to this stage. And this is post-healing and amazing results. Patient was very happy with the things. Another case of laser depigmentation, you see, so black her gums were. Now this is immediately post-surgical laser, and this was much better. She has some lip deformity. So she went for veneers also. These are temporary crowns which we have given before the final veneers. And from here and here you can see some patches are still there which can be taken care in the next few appointments. So this is again a small video, few seconds, which will tell you how simple laser depigmentation is. We think it might be something so difficult to do. We are just scraping the tissues with a laser. That's all you need to do it. Sometimes it is advised by periodontists you do it with a blade. You scrape it with a blade, the deep melanin pigment. But if you have a laser, you can do all that. So simple, easy procedure to do. Okay? And you have to keep scrubbing that pigment with a hydrogen peroxide simple 0.1%, and that helps in removing the black pigments. Okay, so I'll just stop that. Now coming to crown lengthening, further cases, a beautiful result as you can see here. Lot of gingival display. Now you see how good her smile is. She was not very happy after orthodontic treatment. One of her sides had a lot of gingival display. So we did selective cutting of this area, as you can see. We did we always mark with a laser tip first. Check before that we check it with a obviously periodontal probe. We cut the gingiva, and you can see here the tooth has come out. Now we have added composite resin to it. We don't need any more veneers, just a composite addition, and see from here we have reached to this stage. So it makes a difference. Simple procedures. Smile has improved from this to this stage with just half an hour job. Procedure again, space closure, unequal appearance of two incisors. Patient will never be even happy after closure of all the spaces. So we did all that. We realized after closure, patient had a lot of bulbous gingiva present. Obviously, frenum was high. So we went for selective gingival trimming and also frenectomy. And here you see her gum has really improved. Her smile has improved. Patient was very happy. The retention of plaque is drastically reduced. Again, a case in which there was a midline diastema. Total deep bite, we use micro implants, push up the teeth. As we do that, again, as I said, the gum tissue accumulates. See the difference in height of the implants with the tissue, it has reduced drastically. We went for laser crown lengthening, and you see here the patient's profile, everything has improved drastically. This was not just possible with orthodontics. You have to have certain adjuncts to do that. Okay, you see here, we have done this frenectomy. Avoid getting black. Still, I have these black things. They should not be there. Sometimes you get anxious and over enthusiastic to do the procedure. And as I said before, do cutting from both sides. This is the biggest mistake. People do only cutting on labial surface. So here we see beautiful result. So showing another case, very frequently come in our practice, that a retreatment case in which there was missing lateral incisors. So canines were there. So what we did with orthodontic treatment, we created the space for lateral incisors and asked the patient to go for implants, which she refused. She said she don't want implants. So we had the option of giving cantilever bridges. These are the only places in our mouth canine के साथ हम lateral का cantilever दे सकते हैं. So we went that, but before giving that, patient was not very happy. She said, these two crowns are very short in height, because somebody had already cut those teeth. So we did a crown lengthening procedure. Now this starts looking like a canine. Previously it was looking like a lateral incisor. Now it looks like a canine. So here we have given temporaries, and final result, patient has got an amazing smile with these cantilevers. The tooth looks all similar in size. So we see beautiful results. Again, another case. Here I didn't need any micro implants. I did first pupil extraction, intrusion mechanics, and you see here beautiful smile from here. The cant has also been improved. And we had reached a stage, there was so much of gum collected all around because we have done retractions and intrusions. So we went, again checked with the probe, went for a laser removal, and you see here, her smile has improved. She started looking much more prettier. Okay, now another situation as an orthodontist we come across is the exposure of impacted teeth. See, I am telling you all these cases so that you feel it is so simple if you have a gadget lying along with you. So in cases where there is a stubborn tooth which is not opening up, like in this case, there was a lateral incisor, we started opening up the space. Obviously, best method recommended is do a full thickness flap surgery, bond a bracket there, start pulling it down. But this was a child who was so apprehensive, never wanted any surgical procedures at any cost. But that is always a full thickness flap surgery is most recommended way of doing it. So we have bonded, and then we were able to ultimately get the tooth down. Another case, a child just 6 to 7, I think 8 years, this tooth was not coming out for 1 year. I always tell my patients, you wait for 3 months, show back. Wait for 6 months, show back, it will come out. But it was not coming out for 1 year. A simple incision here, and this tooth started coming out. So if you have a laser, things work fast. Palatally placed canine, we exposed it. As we were bringing it, lot of fibrous tissue accumulated. We cut the tooth all around and brought the tooth into the occlusion. As you can see, this was not possible without a simple adjunct. Okay, so another case, this was again one of the stubborn teeth, a dentist patient. This impacted canine, I had created space. 1 year I waited, it was never coming out, got exposure done, started pulling the teeth, and we were able to finally bring the teeth out. So now, since there are general dentistry things, some of them are also there. So we need for prosthetic purpose where we need lasers. As we see a patient of trauma here, we had on the day of bonding itself, this trauma happened actually. So this tooth was all broken from palatal side also. So we were not able to see the tooth. We did cutting of the laser from all this area. We were able to get the tooth, did post and core, everything, and we brought up the tooth. And finally, as you can see, we bonded and ultimately got a good smile. So from here, we finished our case in a good smile to a patient. Again, another case, again, before bonding, this tooth broke. Nothing was visible. We built up the whole tooth and gave a gum-colored composite, exactly not matching, but slightly better than a full composite thickness. So again, as I said, we did a crown lengthening with a laser, post and core, pin and retained restoration, brought the tooth down. This is all I do in my practice. As I said, this tooth was looking bad, so we added a Ivoclar gum-colored composite, and this was there, and we were able to achieve a better result. So another case in which instead of somebody had crown lengthening and posture core, and then brought this canine into front. Obviously, did the top control, and here we close all the teeth and close all the space. So sometimes you have this gingival polyp type of thing growing into the tissue. Simple, cut it. We were using this blade or putting formocresol and pushing into the gum area. So this works better. All this procedure of cutting, building, post and core, pin retained, everything was done in just half an hour, and you earn quite a bit out of it. And again, a case, just few more cases to share. For smile designing, this patient had a tilted side down. As you can see here, we with micro implants pulled this up. Again, the tissue started accumulating here, and we now the cant has improved so much, as you can see here. And you see, the aesthetics have tremendously improved. Without laser, it would not have been possible. See, beautiful results. Just 6 to 8 months, maximum a year. I do a technique called Speedo Orthodontics. We use low intensity laser stimulation. It works. And this is a case in which you see a beautiful result, putting a veneers and crowns. The patient had a small clinical crown. If I had put a new crown, it would not have been giving the same results. So we did crown lengthening on all the teeth which was required, took the impressions, same day, everything, and you see, we gave her this crown and 3 veneers on the side, and she had amazing results, as you see here. Again, a case, I thought, shall I take it or not? A very difficult trauma case. Tooth was all broken, everything gone. So we again did crown lengthening, built up the tooth, started the alignments, and as we continued with microplants in lower, and we ultimately got a beautiful result. He didn't go for again implants, so we see we had to give him crowns only. So from here, he got a beautiful smile like this. Okay, so if a patient came with such crowns, if I would change the crowns, it would be never a good procedure to do. We did crown lengthening in lateral incisors, we did bone trimming also, and then we added composite, did the crown length cutting procedure, and ultimately you see here, we have given wonderful crowns, all 6, 8 metal-free crowns. From here, we reached here, from here, a beautiful result. In lower incisors, there was hardly any visible space, so we did the crown lengthening procedure, and ultimately we gave a 3-unit crown. At times, a lot of patients, they don't get ready for implants. Again, a case in which there was a lateral which had totally moved into the space of central incisor. We wanted to do orthodontic treatment. Patient had only 1 week before her marriage. It was not possible. So we did cutting of gum here, as you can see, and we added composite in 1 step. In 2 hours, we were able to give a reasonably good result. I was not very happy, but patient was quite happy with the result. She needed much better than that, but it was her marriage. She wanted this result. Again, a case, after orthodontic treatment, I could reach this stage. The crowns were very short. We did lengthening, additions, and you can see here. So you have to add adjuncts. See, beautiful smile she has got. Here, final result. Again, a case, he needed crown lengthenings, veneers, We were able to give all this in just 2 hours, and seriously, you earn quite a bit out of it. Another factor which add to it. So again, we use crown lengthening and procedures for doing posting course. We do exposure of tissues, and we get amazing results. As you see here, from here we reach to this stage, and here, so. Okay, and one thing which we very often come get patients, last few slides, is a third molar issue. You are asking a periodontist or an oral surgeon to come and do operculectomy for you. So get your X-rays done. If the tooth is out of the bone, laser operculectomy, it works like a magic. And you see here, all this tissue has been cut. It looks quite bad, but within week, whole of the tooth was out. Patient was very happy. Here the tissue is so inflamed, and the tooth looks absolutely fine. And one more thing, if you have a laser, patient comes with aphthous ulcers, just put the laser there for a few seconds. All that pain and trauma will go within minutes and within seconds. Patient will go very happy. And also, if patient has hypersensitivity on certain teeth, even after orthodontic treatment, put this laser without the tip on that hypersensitive area, do a curing, hypersensitivity will go. Patient will again go very happy after that. So just again to tell in the end that lasers have a lot of benefits, less damage to surrounding tissue, reduced risk of infection, minimal invasive procedure, no stress, no drills, no needles, nothing required. So I will end my presentation with few sayings by one of the said by the great guy Steve Jobs, who said that you have to go out and expose yourself to the best of what others have done, and then bring back some of it and add to what you're doing. So this is what my model has always been. I go to presentation, my target is only one thing I want to carry back from that presentation. I hope I have been able to stimulate you people to use one of the adjuncts, whatever you feel like, to add to your practice so that you can improve your results. So our aim, as I said before initially, is a good smile, and we can achieve that. And I want to thank everybody and for giving me this opportunity, and especially Dr. J.K. Singh sir, Dr. J.K. sir, thanks a lot for giving me this opportunity. It took me 28 years to come and speak in this platform. I've spoken across the globe, but this is my most cherished moment. I feel very emotional. I have been able to speak in this platform. I had dreamed of it long time back. Thanks a lot to everybody who has made it possible. Thank you.
Thank you, sir, for your valuable talk on the laser and sharing your finding with all of us. Thank you, sir. Now, I request Dr. Trustee Dikuman, please give token to gratitude to our speaker of the day, Dr. Sarabjit Singh, sir. Thank you, sir. Thank you, ma'am. Now I request our second speaker of the day, Dr. Pradeep Rawat, sir. Dr. Pradeep Rawat is a professor and head in the Department of Orthodontics and Dentofacial Orthopedics, and he is also the Dean Student Welfare of Vivekanand Subhati University, Meerut. Sir has 86 papers all over publications in various international and national journals. He is the executive committee member of Indian Orthodontic Society for last 10 years. He has organized various national conferences and conventions, and currently he is the editor-in-chief of Journal of Contemporary Orthodontics, JCO IOS, and he has delivered various lectures, talks, auditions, and organized various workshops in the convention and conferences. Sir has
wherever I am standing today. So first of all, I would like to give my charans first to all the teachers who has taught us and who have made us what we are today. So that's a beautiful alma mater where we have studied from first year. Then I joined this college in 1989 in BDS, and then in 1996 I joined MDS. I passed out MDS Orthodontics from this institution in 1999. So this is the photograph when we were in first year and we were giving farewell to our seniors. So you can see all the teachers who had taught you also here. You can see at that time Dr. D.N. Kapoor was the head and dean of our department. Dr. V.P. Sharma sir, Dr. Pradeep Tandon sir, and the senior resident Dr. Dinesh Bagga and all our senior batch. You can see, and we three, the batchmates, we are sitting in the front. Me, along with Dr. Jiten Shakya and Dr. Sandeep Goel, we were in the first year at that time. So I again give my challenge first and I gratitude to all my teachers. And that's just before final year. This is my batch with our guide and head of the department, Dr. D.N. Kapoor sir. That's me. Maybe you will not be able to recognize me because now I am, I think, triple or four times I have increased in size now. So today I will be talking about a very interesting topic, that's accelerated orthodontics. Now that's a very hot topic because we all know that as an orthodontist, we always, one of the main disadvantage of this treatment was that it was a very prolonged treatment. It took at least 1.5 to 3 years, 4 years. And because of this, many times patients were reluctant to go for orthodontic treatment. And that's why this topic nowadays is one of the hot topics for research also, and it is also relevant for all of us because it can have an effect on the overall practice as well as the patient convenience also. So today I will be talking about what are the present prevalent notions about accelerated orthodontics against what are the established scientific facts, because we all are living in the era of the evidence-based dentistry. So I will be talking about the scientific evidences. I will be sharing some of the research which we have done in our department on accelerated orthodontics. That's the university where I am presently working. It is Swami Vivekananda Subharti University, and that's Subharti Dental College where I am presently professor and head. So this is a famous saying of Ackerman, which was in 2007. He said that orthodontic treatment time is an important factor for patients to consider when making treatment choices. And if we can reduce the overall orthodontic treatment duration, in that case, there will be certain advantages. What are these advantages? The advantages, of course, would be that it would be associated with shorter treatment duration. And along with this, there are various side effects which are associated with prolonged orthodontic treatment time. And these are like dental caries, root resorptions, or oral hygiene related problems. So we will be minimizing all these problems also. Probably we can enhance the envelope of tooth movement. We can also achieve differential tooth movement. And we may also be able to improve the post-treatment stability also if we are successful in accelerating orthodontics. So before moving forward, I would just like to briefly tell about the various theories which has been given for orthodontic tooth movement. The most oldest theory was the direct theory, which says that whenever we are applying a force, in that case, the main target is the bone cells, and the mediators are the matrix deformation of the bone, and the main executors are osteocytes. And because of this, there is remodeling of the bone. Presently, after this came the indirect theory. The indirect theory says that actually the target cells are the periodontal ligament. Whenever we apply orthodontic force, it will lead to inflammation and damage or trauma to the periodontal ligament. And because of this trauma, there will be release of various cytokines, mediators, which will cause osteoclastogenesis or the activation of osteoclast and osteoclastogenesis. This is the most prevalent theory which all we are following till today. But in 2018, Mani Ali Khani, he gave an alternative theory to this. He said, he had the biphasic theory. Now, what is biphasic theory? Actually, in indirect theory, both the osteoclastic activity as well as the osteoblastic activity, they are taking place simultaneously. That means that on one side where there is a pressure, there will be bone resorption or osteoclastic activity, while on the side where there is tension, on that side there will be bone deposition. But according to biphasic theory, the inflammatory markers which are released because of trauma to the periodontal ligament whenever we apply an orthodontic forces, there is always an initial osteoclastogenic activity. That means that there is a delay between the osteoclastic process and the osteoblastic process. Osteoclastic process he named as catabolic process, and osteoblastic process he called it as anabolic process. So according to biphasic theory, always whenever we are doing an orthodontic tooth movement, initially there will be a catabolic activity. That will be there will be increased activity of osteoclast. Once there is an increased activity of osteoclast, thereafter, after certain amount of delay, there will be an anabolic activity, or there will be an activation of the osteoblast. Okay, so in nutshell, we can say that biphasic theory says that for orthodontic treatment of our orthodontic tooth movement, actually the activation of osteoclast is very important, and thereafter the osteoblastic process will ensue. And in fact, most of the studies which has been done on the orthodontic tooth movement, they have also shown that in the initial part of the tooth movement, there is an increased osteoclastic activity as compared to osteoblastic activity. So this theory actually was given considering the isolated orthodontic tooth movement, because most of the methods which are being used and which claim that they can increase the rate of tooth movement, actually they claim that initially there is an increased osteoclastic activity. And this is the pathway through which most of the tooth movement, the increase in tooth movement is initiated. You all must be aware, rank, rankle, and OPG. Rank is the subsurface receptor which is present on the osteoclastic precursors, while rankle is the ligand which is present on the osteoblast. So the combination of rank-rankle will cause the upregulation of osteoclastogenesis, and upregulation of osteoclastogenesis will cause an increased rate of tooth movement. And there is a decoy receptor, you all must be aware, OPG. If OPG is increased, in that case it will cause down regulation of rank-rankle receptor pathway, and because of down regulation of rank-rankle, it will cause decrease in osteoclastogenesis, thereby decreasing the tooth movement. So most of the method which we will be seeing now and in my presentation, they all basically work on this basic principle that there is an upregulation of rank-rankle expressions which will causing the increased osteoclastogenesis, therefore increasing the rate of tooth movement. So there are various methods of accelerating tooth movement. These are the first is the biological approach. It is not a very popular approach, and most of the studies on this all presently are mainly animal studies because of the ethical issues. Very less human studies are there, because in this we have to give injections or applications of various chemical mediators or various chemicals like prostaglandins, cytokines, vitamin D3, parathyroid hormone, or relaxant. This is the most acceptable method, and this is the method, the surgical method of accelerating orthodontic movement has got the most promising results in terms of increasing the rate of tooth movement. This consists of these three: osteotomy facilitated, corticotomy facilitated, or distraction osteogenesis, piezofusions, or microaustral perforations. And third, then nowadays various devices are also coming through which we apply an external stimulus onto the tooth movement area, like application of electromagnetic field or application of low-level lasers, resonant vibrations, low-level intensity pulse ultrasound. I will not be discussing all these things. I will be discussing only the most popular and prevalent method which are presently being used for accelerating orthodontic tooth movement. Now the question comes, when you have got so many methods which are prevalent in the market, you will see the literature is flooded with many of the methods which are claiming that they can increase the rate of tooth movement. So which method to choose? Which is the best method? What is its effectiveness? what are the various considerations while making the decisions that which this method is the best, and what may be the short or long-term effect of these all these methods. So today we will be discussing all these things. If you search the term accelerated orthodontics in PubMed, you will see that till 2013, there were very less publications or less research done on this topic. The increase in this topic has actually increased suddenly after 2013. Okay, so after this, actually, this topic became a very important topic, very hot topic for research, and that's why there is a search. As you can see, the heights of the columns in this showing that nowadays every journal will have at least few publications on accelerated orthodontic movements. You will get a lot of articles. There are a lot of articles which are present on various methods. I will be today talking about the microaustral perforation first. Now, why microaustral perforations? Because microaustral perforations, the surgical method has shown very promising results. But surgical methods is an invasive method. Whenever there is an invasive method, it will require the raising of the flaps. Then you will have to make incisions also. So that has got associated complications or morbidity also. Microaustral perforation actually is a controlled trauma, a very, very controlled trauma. And that's why it is becoming more and more popular. And all these methods which are related to trauma are basically based on the principle that there is an induction of RAP phenomena. RAP is regional acceleratory phenomena, and regional acceleratory phenomena is that whenever we cause any trauma will lead to an increased inflammatory process, and this increased inflammatory process will cause an increased osteoclastic activity, and because of this there will be alveolar osteopenia, calcium depletion, diminished bone densities, and decrease in the cortical bone density. Because of the decrease in cortical bone density, there will be decrease in the resistance of the tooth movement, and that's why there will be increase in rate of tooth movement. So microaustral perforations, it is done there are many devices which are available. The most commonly commercially available device is the Propel. Propel is slightly expensive. After Propel, many of the researches which have been published, they have used simple TAG, a temporary anchorage device for puncturing the bone. Because in microaustral perforation, what we do, we just do a perforation of the cortical bone. The perforation is done to the depth of 2 to 3 millimeters, and the diameter of this perforation is 1.5 millimeters. So it is the least invasive of surgical method. That's why it is the most popular method also. And again, the underlying basis for this method again is the same, that it causes an inflammatory process because of there is the release of the cytokines, and these cytokines will cause an upregulation of the rank-rankle pathway, leading to increase in the rate of tooth movement. So if we go to the literature and we search, then we will find that almost there are still contradictory results are seen. Many of the researchers, many of the systemic reviews or meta-analysis, they say that there is some effect of microaustral perforations, while some of the methods, some of the researches, they say that there is no effect of microaustral perforations. There is a weak evidence to link that there is an effect of microaustral perforation on accelerating tooth movement. So what is our experience? We have done 2 or 3 researches on microaustral perforation for accelerating orthodontic movement. Now this is the first research which we have done. This is published last month only in the Dental Press Journal of Orthodontic, which is a prestigious journal, and this was basically effect of microaustral perforations on the rate of tooth movement and expressions of biomarkers. It was a randomized clinical trial. So this trial was a single-center randomized clinical trial. This was a split mouth design study, and we recruited 30 adult subjects with an allocation ratio of 1:1, and we did 3 microaustral perforation in the extraction site vertically at equidistance, exactly in the center of the extraction space before retracting the canines. This was done only for evaluating the rate of retraction of the canine, just the distal movement of the canine. So the experimental group received 3 microaustral perforations, while the control group received no microaustral perforations. The primary outcome was to evaluate the rate of canine retraction, which was measured on the study models from the baseline to 4 months. After every 4 weeks, we used to evaluate the rate of tooth movement. And this was the method which we have used for evaluating the rate of tooth movement on the study models. And along with this, the secondary outcome was that we also wanted to know the level of the biomarkers, which are related to the bone resorption and bone deposition. And done for the first month before microaustral perforations, after first week, second week, third week, and fourth week. We did not do this study beyond 1 month because of certain methodological constraints, because of the availability of the material or the availability of the lab which was there for this. So this was our result. Primary outcome, the mean rate of space closure on the experimental slide was significantly higher on the experimental side as compared to the control side. But thereafter, after the first month, actually there was no difference. That means the effect which we saw of the microaustral perforations was only for the first month. Thereafter, in the second month, third month, and fourth month, there was no effect of microaustral perforations on the rate of tooth movement. And similarly, the alkaline, the biomarkers also shown that there was an increase in the level of biomarkers in the first month. Since we did not get the evaluation of biomarkers after the fourth week, that is after 1 month, so we were not sure that whether this increase in level of biomarkers will remain after the first month also. So the conclusion of this study was that microaustral perforation will only temporarily increase the rate of tooth movement, only for the first month. Thereafter, there will be no difference, and there is definitely an increased level of biomarkers of the tooth movement in the initial phase of the microaustral perforations. This was the first study, and then this is another study which, because in the first study which we evaluated the rate of canine retraction. Then we thought that why not to evaluate the whole en masse retraction. So this article was published in the Journal of Oral Biology and Craniofacial Research. And in this, we evaluated the rate of tooth movement by an en masse anterior retraction after the extraction of the first premolars. So this was also a randomized clinical trial with the elevation ratio of 1:1. In this, we recruited 60 subjects, out of which 30 were given to the experimental side. In this, since we were doing an en masse movement, so we thought that 3 microaustral perforation would not be sufficient enough, and that's why we increased the number of mobs to 5. There were 3 microaustral perforation in the extraction side, and we did 2 additional microaustral perforations in between the lateral incisors and canine, so that we can have an enhanced expression of the biomarkers of inflammation. And in this, we did the laser scanning of the models, and we did this measurement on the laser scan models. So this was the result. In this study also, ironically, we observed that the increase in rate of tooth movement was only in the first month. In the first month, there was definitely a statistically significant increase in rate of tooth movement in the first month, but thereafter there was no difference. That means in this study also we observed that the increase in rate of tooth movement is temporary only for the first month. In second, third, and fourth month, there is no effect of microaustral perforations on the rate of orthodontic tooth movement. So this was the conclusion, same conclusion as we have got in the previous study also, that microaustral perforation did not accelerate the rate of anterior en masse retraction over a period of 4 months. However, it temporarily increases the rate of retraction only for the first month. So what does the evidence say? I have shared my research. Now, evidence means we have to have a high quality, either randomized clinical trials or meta-analysis to say that yes, definitely there is, we can correlate that microaustral perforations has got some effect on tooth movement. So let's see one of the latest meta-analysis which was done by Sarita Sivarajan and others, which were published in AGODO 2020. and they included 8 articles. Out of these 8 articles, 3 were having a high risk of bias. 3 studies were having low risk of bias. Only 2 studies were having a questionable bias. So out of these 8 studies, actually 6 studies, they favored that there is an effect of microaustral perforation on rate of movement. But what was the problem with all these studies? If we see that these 3 studies, they have actually done the microaustral perforation with the help of Propel device, while remaining studies, they have used a TAD, simple TAD. So there was lot of variability in the methodology of all these researches. So there was heterogeneity in the studies. So whenever there is a heterogeneity of the studies, then it is very difficult to combine the data, to do a qualitative synthesis and to do meta-analysis. So in this, finally they did meta-analysis only on these 2 articles because they were having a similar methodology, and because of heterogeneity, they could not include all other articles. And what they found that there is no effect of microaustral perforations, or there is very weak evidence to say that microaustral perforation will increase the rate of orthodontic movement. So presently, what is the ambiguity? What are the confusions on this topic? There is ambiguity in terms that presently most of the studies on microaustral perforations, they have been done only for a very short period of time, either 1 month, 2 months, 4 months, 6 months. Okay. When we are saying that a method will reduce the overall duration of orthodontic treatment time, then we have to have a study which will actually do this procedure and then evaluate the overall duration of time. Then only we can say that yes, this method has got some helpful, it is advantageous in orthodontic movement. And that's why this is the problem in this research, in various articles or various researches which have been done on this topic. We are not aware about that what will be the effect of repeated mocks. There is a lot of methodological heterogeneity in most of the researches. So that is the ambiguity which is present there in the topic, on this topic. So now I will be just giving an explanation that what could be the reason why in our study we found only the result or a temporary acceleration for the first month only. It was basically, if you see this, this is an animal study which was done by Texera and Cohen, and they did the biomarker evaluation after doing the microaustral perforation or minor incision in the bone, and they observed that actually there is an increase in the level of pro-inflammatory markers only to the 2 to 4 weeks. After 4 weeks, actually there is no, the level of biomarkers again come to the base level. That means that may be the reason why in our study which observed that initially there is an increase in rate of tooth movement only till the inflammatory process is there, till there is an increased level of biomarkers. Once this biomarker level comes to the base level, then there will be no effect of this microaustral perforation procedure on the tooth movement. So the question comes, if this is so, then if we go for repeated mocks, if we are saying that mocks will only temporarily increase the rate of tooth movement, only for 1 month, if we think that if we do microaustral perforation after every 1 month, then probably we will have a constancy in the rate of tooth increase in rate of tooth movement. Okay, so we again searched various articles. So this is one of the latest meta-analysis which were published in 2022 only. And this is the effect of single and multiple microaustral perforations on the rate of tooth movement and its possible complications. They included 16 studies in this, and 8 studies were at low risk of bias, while the remaining 8 were having a high risk of bias. And again, as I have just told, that there is a lot of variability in the methodology. Most of the methods, researchers, they are using different methods for evaluation of tooth movement. So it is very, very difficult to correlate that data clinically. Yes, that definitely it will be having an effect on increasing rate of tooth movement. So this meta-analysis, although they concluded that yes, there is definitely effect of there definitely increase in rate of tooth movement after repeated microaustral perforations. Okay, but four of these meta-analysis. In this, actually, they did an overall analysis. So in quantitative analysis, they observed definitely there is an increase in rate of tooth movement whenever we do the repeated microaustral perforation. That means after every if we repeat the microaustral perforations, it will definitely increase the rate of tooth movement. But the meta-analysis again showed here that actually there is very weak evidence to show that microaustral perforations will increase the rate of tooth movement. So that means again we are standing at the same crossroads, that still we doesn't have very strong evidences to say that microaustral perforation will definitely have an effect on orthodontic tooth movement. We need more controlled randomized clinical trials with a more specific methodology so that we can come to the conclusion regarding the effect of microaustral perforation during orthodontic tooth movement. So now I will be coming to the second method, that is vibratory method. So we have done one research on this method also. If we go to the research, if we search the literature, we will again find there are a lot of contradictory results. Vibrating devices, there are 3 vibrating devices presently which are used. First is the SL-Dent. SL-Dent is again a commercially available device. Second is the tooth messieu. Few of the researchers, they have used tooth messieu also. And in the middle, few of the researchers, they have actually done research on vibratory toothbrushes also, the power toothbrushes also. So the vibratory devices also work on the principle that whenever we apply intermittent force, it will cause vibration micro pulses, which will enhance or which will do the upregulation of the rank-rankle pathway, leading to increase in osteoclastogenesis, thereby increasing the rate of tooth movement. So vibrational devices, actually, they are again defined by frequency and magnitude. Presently, there are a lot of devices which are available. The different researchers, they are using different models for this. So therefore, again, the same problem which I was just referring to in the microaustral perforation, the same problem actually is in the studies which have been done on vibratory devices also. The literature again is inconclusive. You will find certain studies which says yes, there is an effect. Some studies, they say there is no effect of the vibration on the tooth movement. Now I will be showing one of the experiments the research which we have done in our department. So this is the latest article which has been published recently in the Journal of Orthodontic Science, in the Saudi Orthodontic Society Journal. This is the effect of customized vibratory device on orthodontic tooth movement. This was also a prospective randomized clinical trial. This was the device, actually we made a customized device. And this customized device was vibrating at the frequency of 30 Hertz, and it was applying a force of 20 newtons. Okay, the same frequency and magnitude which has been applied by the SL-Dent appliance also. And in this sense, when this study was designed as a split mount design, that's why we customized this in the way that only half was used. We have got a patent of this device, and now we are going for commercial production of this device also. Of course, it will not be with this half tray. It will be with a full tray, along with the vibratory system, which is there in the bottom product. So this was a single center split mount randomized clinical trial. We included 30 subjects, and we did the measurement on the laser 3D scan models. So in this study also, we observed that there was no effect of vibratory device on the rate of orthodontic tooth movement. There is no effect of vibratory devices. Presently, there is no evidence to show that there is effect of vibration on the rate of tooth movement. So what does the evidence says? What are the various, so this is again one of the article or very good meta-analysis which was done on effectiveness of various vibrational devices. So again, same thing. What I am trying to tell is that presently most of the researches which are coming out on accelerated orthodontic movement, there is no consensus, there is no specific methodology. Every person, every researcher is using a different methodology. As you can see here in this meta-analysis, they showed that most of the appliances they are using for different time periods, they are using a different type of frequency module, they are using a different type of force module. So it was difficult to actually combine the data for meta-analysis and the same results. That in this RCT also, they observed that there is very weak evidence to show that the vibratory devices will have an effect on orthodontic movement. The result from meta-analysis also showed that there is no link between the accelerated orthodontic movement and vibratory devices. So what are the ambiguity in the researches on vibratory devices? First is there are different vibratory devices. There is no specific protocol. There are varying frequencies of these devices also. There is no specific frequency which we should use or which we claim that is the best frequency which can have an effect on rate of tooth movement. And there is a lack of standardized protocol for the research. So these are the unanswered questions on vibratory devices. We are not aware about which is the most appropriate frequency. We are not aware about what type of vibrational device we should use. Should we go for a higher frequency vibration or should we go for lower frequency vibrations? What should be the design of a standard device? So these are the various unanswered questions. So still we have to go a long way to know the effect of vibration or orthodontic tooth movements. So we need a further research on vibratory devices. We need a further high quality randomized clinical trials with a homogeneous methodology to say that yes, the vibration has got some effect on orthodontic tooth movement. Now coming briefly about the low-level lasers also. Low-level lasers, again, as my previous speaker, Dr. Sarabjit Singh has told, that low-level lasers, actually, again, a lot of research has been done on this also. And low-level lasers actually work on the same principle that when we apply laser radiation onto the cells, the nucleus will absorb this high energy and it will cause a biostimulation. And because of this biostimulation, there will be production of energy, production of ATP. And because of this production of ATP, there will be activation or upregulation of the Rankel pathway. And because of this, there will be increase in rate of tooth movement. So there again, same thing. Again, I am repeating the same. The research in this also have got a lot of heterogeneity. There are several parameters which are describing low-level lasers. Laser power is there, wavelength is there, pulse rate is there, intensity is there, electromagnetic spectrum is there. Most of the researchers, they are still having different variations. There are a lot of variation in there on the studies which has been done on low-level lasers. The literature is flooded. It is contradictory results. There is no conclusion. Some say that yes, it has got some effect on rate of tooth movement. Some say there is no effect. And this is again an article published in March 2022, which was systemic review on effect of photobiomodulation or low-level lasers on orthodontic tooth movement. And again, this was the photograph which I took from a screenshot I took from their table of the articles which they have taken. And you can see here the wavelength. There's so much of variation in the wavelength. There's so much of variation in the energy density, power output, exposure time. Still a lot of variability is there. And in fact, this meta-analysis and systemic review, it concluded that the results were inconclusive and cannot be generalized to the public community. So the ambiguity in terms of low level, again, is the same, that the majority of RCTs which are related to accelerating the tooth movement in orthodontic treatment are ideally between 780 to 850 nanometers. Laser dosage again is a problem. We are not aware about that what should be the most appropriate laser dose. we are not sure that what are the long-term effect of the lasers. We are still not sure about optical protocols also. Okay. And most of the studies actually on lasers or vibrations, what they have shown actually an increase in the rate of tooth movement only by 24 to 50%, 24 to 30% only. And maybe statistically it may be significant, but 24% actually comes to 0.4 to 0.8 millimeters increase in rate of tooth movement. Do you think that this increase in rate of tooth movement is clinically significant? Will this translate into overall reduction in the orthodontic treatment time? We do not know. We have to do more research to know exactly that whether this will have an effect on overall reduction of orthodontic treatment time. So now coming to the last part of my presentation, what are the various recommendations for clinical practice? Are we really interested in clinically performing the accelerated orthodontic treatment? Yes, definitely we are interested because it will benefit our patients. There will be less orthodontic treatment duration time. More patients will be convinced for going for orthodontic treatment. But this is a survey by one of the Illinois who conducted a survey to know that whether orthodontists are interested in this, and 70% orthodontists said that they will consider additional clinical procedure to reduce orthodontic treatment time. And even there is a reduction of 20 to 40% reduction in treatment time. It was significant enough to implement clinical procedures to speed the treatment. But what is the problem? Problem is presently there is lack of demand of all these procedures. Most of the persons, they are only doing research. This method presently has not been translated into the clinical practice presently. Most of the methods of accelerated orthodontics. Secondly, most importantly, there is lack of scientific evidences. As I just shown you, most of the meta-analysis, most of the systemic reviews, they are not clear. At the end, they say that there is very weak evidences. So presently, there is lack of evidence. And since we are living in an era of evidence-based dentistry, so till we have got any evidence, it is very difficult to apply those methods into our clinical practice. Patients will definitely prefer the methods, but they will only prefer non-invasive methods. If you will tell the patient, yeah, I want to put hole in your bones because I want to decrease the rate of tooth movement, they will no, I don't want to go put my holes in my bones. Who would like to go for this? Okay, so this non-invasiveness procedures may have got some acceptance by the patients, but invasive method, and I have got a very strong doubt that patient will be accepting the invasive methods for accelerated tooth movement. So, and secondly, if you are using any additional device for this, definitely it will have an impact on the rate also. You will have to increase the charges also. So whether the cost benefit and risk benefit analysis, you have to see this, the amount of payment or amount of charges we are doing there, whether it has got a benefit in terms of the increase in the rate, or it has got the benefit in terms of the patient acceptance or reduction of orthodontic treatment time. So again, we have got time. We need more researches to show that yes, definitely it has got more benefit as compared to the risk when we talk about all these methods. So most predictive factors in patient acceptance to accelerated orthodontic tooth movement will always be dependent on invasiveness of the procedures. There will be always a question mark, and the financial concerns. But only when we will solve these two procedures, these two things, these two factors, then probably we will be able to use these methods for our clinical practice and for advantage of patients. So what do we need? Still, we are very far away from actually any method which can increase the rate of tooth movement and which can overall reduce the orthodontic treatment duration. We need more robust, well-designed clinical trials with fixed guidelines, extensions, with clinical trials involving surgical interventions. Remember, it is critical to follow IDEAL. What is IDEAL? IDEAL is idea, development, exploration, assessment, long-term follow-up, improving the quality of research and surgery. Long-term follow-up is again very important. till now, none of the study on this acceleration of tooth movement has shown long-term effects. Till we are clear about long-term effects, we cannot apply this method into our clinical practice. So finally, to conclude, what is the best method to increase rate of tooth movement? This is the conclusion from my presentation. Perhaps the most best and predictable approach to shortening the length of orthodontic treatment is to diagnose the malocclusion properly, plan the treatment carefully, so the mechanics used during the therapy minimizes the undesirable side effect. Automatically, you will get the treatment in the minimal possible time. So that's the conclusion of my presentation. Thank you very much for your kind listening. And I again would like to convey my sincere regards and my deepest respect to all my teachers. Presently, Dr. Pradeep sir is sitting here. He was the most lovable teacher at our time. When people were fearing for other teachers, but we could go to him anytime, anywhere, and we could also go to his home also. Sir, this is the way of confusion, or as sir, please samjha do. Thank you so much, sir. And I would like to also acknowledge Dr. G.K. Singh, sir. He was my senior, and all the department for giving me this opportunity to speak in this August gathering in front of my teachers and the same alma mater where we have learned everything. Thank you so much. Thank you.
Thank you, sir, for your valuable words on the topic of accelerated orthodontics. And I request Dr. Professor G.K. Singh, sir, kindly give the token of appreciation to Dr. Pradeep Rao, sir. Thank you, sir. Now I request Professor G.K. Singh, sir, kindly conclude the session. Thank you, sir.
I am thankful to all of you who are present in this hall, and I am thankful to the speakers, especially Dr. Sarabjit Singh, who comes from so far from the Chandigarh, and by all efforts, and he has given us too much time. He is still here for today and tomorrow, and for us to manage the World Orthodontic Day also tomorrow morning. So I am extremely thankful to Dr. Surabjit Singh, who explained the use of lasers in a different way in the orthodontics as well in the dentistry, for the lengthening of the crown and the fabrication of the crown and all. That's a elaborate lecture on the lasers in orthodontics. Thank you, Dr. Surabjit Singh. And I'm extremely thankful to Dr. Pradeep Raghav, who is my junior, as well as sometime he was my colleague in Subharti Dental College for 2 years when I joined in 2002 to 2002. When I came here, then after he rolled as a head of department in the Subharti Dental College, I'm also thankful to him as he spent so much time with us and elaborated the accelerated orthodontics in the field of orthodontics, what are the various methods of accelerated orthodontics and what are their results, whether they are effective or not effective. So I am thankful to Dr. Pradeep Raghav for giving their valuable time and knowledge to our students and all other alumni of the King George Medical University. And I am also thankful to our alumni, eminent alumni who are present in this hall, like Dr. Arvinder Singh sir. Sir, thank you for your valuable time. You are present here. And I am also thankful to Dr. Rana, Dr. Ramavatar, Dr. Akhil Agarwal, and Dr. Suresh, and all other dignitaries in the hall who has given their valuable time. And so we are a little bit late due to some inconvenience in the big thing because of our vice chancellor was out of campus, so he come late, and then after we have started our program. So ultimately we have finished these sessions, and I hope most of you can enjoy it or you gain something from these lectures, and you will apply in your future also. Thank you for all. Thank you. I am also thankful to my colleagues and my residents who have worked hard for these lectures, and finally thanks to all of you. Thank you.
Second tell about tomorrow's program timing. Tomorrow's program also.
On the morning of the World Orthodontic Day, we will together at the administrative block at 7:30 a.m. and the dress code is white. You can wear your shirt, t-shirt, or the pant white, and then we will start our rally from the administrative block to the main gate of the university. That is gate number 1. And I hope the Honorable Vice Chancellor will flag the rally from the beginning. So it will be a great event. I hope all of you will be there in the morning. Thank you. Sir, please. I invite Dr. Pradeep Tandon sir to give some word of wisdom to all of us. Sir, please come.
I think it was a very good lecture. I have heard about Dr. Raghav. He has given a very good interpretation of the accelerated orthodontics, and I am thankful to Dr. Raghav and Dr. Sarabjit for coming out here and investing their time out here and giving us such a good information regarding the orthodontics. Thank you very much, everyone. Copy was seen by none other than Dr. Caries, who was a renowned orthodontist of the country. When he saw his copy, he said, "ऐसी copy तो मैंने जीवन में देखी नहीं, इस copy को लोग ले जाना चाहते हैं। ऐसी writing और ऐसा हो, कोई फायदा नहीं होगा। He is such a great person, and I would like him to say a few things."
Regarding Arvinder Singh sir, I want to say something. That earlier I have arranged the lecture, this alumni guest lecture for the Dr. Arvinder Singh sir, but due to unfortunately Dr. Vipin Puri sir's guest was there on the same day, so the hall was not vacant on the same day. That's why I have postponed that lecture. We will arrange in the future we will arrange the same lecture in future also. Now, Dr. Vikas.
Thank you very much. This department is, I'm lucky to be a product of Department of Orthodontics and of course as a BDS graduate from this place. I hold KGMC very close to my heart and I want everybody to do very well. Not only from here but anybody from the fraternity should be doing extremely well. And I'm really grateful to Dr. G.K. Singh to have personally invited me today. And Pradeep, who's a dear old friend, happens to be 1 year junior to me, but in our time, a senior-junior relationship was a very different cup of tea. And we continue to maintain that relationship. And I'm very glad to be here between all of you. And with Pradeep's words, he's a friend, so he will naturally exaggerate whatever is the good things about me. But really, I know, I remember that. But the fact is, whatever we have achieved in life is because of the teachers and the companions who joined us. Like Pradeep, Sudhir, all these people, Praveen, they were also stimulating that they made us think. And our seminars were very interesting. I hope you all continue in the same spirit. And your relationship should be for lifetime. Come what may, all your colleagues, your batchmates, you all should ensure that you maintain this relationship. Synergy create career, you will all grow. And Pradeep and Sarabjit, thanks for coming here and stimulating our brains to adapt to the newer things in life. Thank you very much.
Well, this was the first occasion in this year that we had such a stimulating session from Dr. Sarabjit Singh and Dr. Pradeep Raghav. It was a very nice initiative, and I hope that this will continue, and we will be having even more better sessions in the future. I'm thankful to Dr. Pradeep Tandon, Dr. Arvinder, Dr. Sarabjit, Dr. Pradeep Raghav, Dr. Ram Avatar, Dr. Shrish, Dr. Tripti, she has left, I think, Dr. Akhil, and all the alma mater, Dr. Rana, everyone who has come leaving their own work to attend this program. Thank you so much. Thank you to my students also for working so hard for this program. Thank you.
I request you, all participants, please come forward for a group photograph. I request you, please move forward for group.
Sharma sir, if he wants to say anything.
Dr. Sharma sir is online with us, and I would like to pay my thanks to Dr. VP Sharma sir also, that he was with us online. And I forgot to take some few names, Dr. Sonahita, Dr. Vijeta, Dr. Snehilata, they are also with us. Dr. Prachi, thank you all of you for coming here. Sir, Sharma sir, would you like to say something?
यहाँ से स्क्रीन शेयर करना है आप इनको करो जरा डॉक्टर बीपी शर्मा से डॉक्टर बीपी इसी में हाँ यहाँ से तो नहीं हो पाएगी
वही करेंगे ये कर नहीं पाएंगे। हेलो सर, वो स्पीकर मैंने ऑन कर दिया मोबाइल का। ओके ओके ओके